Okay. Hello, everybody. Very nice to see various colleagues have joined. So, welcome to this session, which is entitled Engaging Urban Communities and Social Determinants. My name is Tolip Mirzoev. I am Professor of International Health Policy and Systems at the University of Leeds, and I will chair this session. So we've got an exciting lineup of 5 excellent speakers. So you are all certainly up for a good treat. Before we proceed, can I request everybody to engage with the session? Please do introduce yourselves, say hi to each other in the discussion forum on the right-hand side of the platform. On the right-hand side of the platform, you also will find the live Q&A section, where I would very much encourage you to drop the questions that you would like to be answered. Where possible, please do indicate which specific presenter you are addressing the questions to. But otherwise, if the questions are open, we will then kind of pick them up. Okay, so the layout of this session will be as follows. I will introduce each presenter in sequence. Then there will be a presentation from each presenter. At the end of each presentation, we'll pause very briefly for any quick questions for clarification. And this is where I would like to make a caveat. Please do only highlight questions for clarification only. And then after all 5 presenters have delivered material, then we will have a kind of joint Q&A, question and answer session. Okay? So we will have hopefully good engagement and participation, and please do drop the questions. One more thing that I would like to say before we move on, please ensure that you drop your questions in the live Q&A section of the session platform, because I will not be able to see all the questions in the discussion forum because of the platform, but please do engage with the discussion forum for introducing yourselves or raising or commenting on any issues that do not require addressing. Okay, so without any further ado, I would like to move on to our first presenter, Mrs. Minus Cassandra Ndambo. She is a research fellow in Partners in Health. She's a motivated public health specialist, qualitative researcher with 3 years of experience in qualitative research methods. She developed 5 abstracts, presented locally and internationally, contributed to 2 published manuscripts, and she's currently developing 2 manuscripts which are under review as the main author. She has got, Minus has got vast experience in protocol development, data collection tools, conducting focus group discussions, observations, interviews, and analyzing using Vivo and DDoS. Welcome, Minus, and over to you. Please, go ahead.
Hi there, I'm Minus Ndambo from Malawi. I'm here to present my findings on the study titled Eating Behaviors, Attitudes and Beliefs that Contribute to Overweight Among Women in Lilongwe City, Malawi. That is the presentation outline. I will not take a lot of time on that one. Just a brief background. WHO estimates 2.8 million deaths each year due to overweight or obesity. 35.8 million global deaths are caused by overweight or obesity. Malawi Demographic Survey for 2015-2016 indicates that 36% of urban women are overweight or obese, and 17% of women in rural areas are overweight or obese. However, women's behavior, attitudes, and beliefs in relation to overweight or obesity are not reported in Malawi. Hence, this study was conducted. I have some definitions there: obesity, overweight, and normal weight. I will not spend a lot of time due to limited time. The main objective for this study was to investigate eating behaviors, attitudes, and beliefs of mothers in the context of. We had 3 specific objectives. That's to examine attitudes and beliefs related to obesity among normal weight and overweight or obese women, to examine factors that influence eating behaviors in normal weight and overweight women, and to compare eating behaviors among normal weight and overweight or obese women. This was a cross-sectional qualitative study which focused on women in Lilongwe City, that's area 18 and Kawari. We purposely sampled 13 normal. This sample was selected from an existing study where BMI was already calculated. 7 silhouettes of body sizes were used to determine women's body perception of body image. You can see from my right, there is a picture showing silhouettes ranging from very thin to obese. Now, data analysis was done manually by following principles of thematic content analysis. On results, the mean age of participants was 27 and the majority were married, symbolizing 37%. 2/3 of participants perceived overweight as an indication of good health. About 1/3 of normal weight respondents were dieting, while 2/3 of respondents ate less food just because of poverty, not because of diet. 8 themes emanated from this study. I will just cruise through. The first one is on social expectations for women to gain weight after marriage. There is that expectation that when you get married, you're supposed to gain weight to show that things are moving well. So that exposes women to a lot of weight gain. Women's agency also contributes to weight gain, as women they have that authority on their own. They have that freedom to eat whatever they can eat. So it's socioeconomic status as it exposes women to so much food. Childbearing was another contributor here, as women who eat a lot of food when they've just given birth and gain a lot of weight, but then very minimal weight loss is noticed them to so much food, so much so that they are tempted to eat, they fail to diet. Family planning is also a perceived contributor to weight gain. And then there is occupation. Occupation is in 2 ways. Those that are working are exposed to poor eating behaviors as they eat their lunch away in restaurants. Those that are not working, the housewives, they are also exposed to a lot of food as they stay at home. The last one is on educational level. In conclusion, most overweight women eat large portions and eat frequently. Women are not aware of the burden of overweight or obesity, hence they prefer gaining weight to show that they are doing well in life. The study therefore recommends increased use of health promotion initiatives as a preventive measure. There is need to include eating behavior information in health talks at the hospital. Thank you very much for your attention, unless there are some questions.
Okay, brilliant. Well, thank you very much, Minus. So great case study. I can see there are 1 or 2 questions trickling through, so thank you for those. The questions so far are not for clarification. but more substantive. So I will certainly save them for more substantive Q&A session towards the end of this session. But let me pause briefly well, unfortunately, I think Minus cannot join us for some reason. Maybe it's an internet connection. So actually, I'm just reminded that even if there are clarification questions, then keep them, and then hopefully she will reconnect a little bit later. Okay, so with that in mind, let me move on to the next presenter, who is Dr. Nabil Natavgi, who is an assistant professor of health services, policy and management, and MHA program associate director at the University of South Carolina, Arnold School of Public Health in the United States. Dr. Natavgi's research interests include telehealth, effectiveness and evaluation, and methodologies of patient engagement and research, with emphasis on mixed methods and special interest in engagement of patients, community members, healthcare providers, and other stakeholders. And he will speak about, well, the title of his presentation is "Are Communities Willing to Transition into Learning Healthcare Communities? Evaluating Stakeholder Receptivity Using Community-Based Participatory Research." Nabil, over to you, please.
Hello and welcome to the virtual session of the 6th Global Symposium on Health Services Research, discussing learning healthcare communities. My name is Nabil Natavgi, and I'm Assistant Professor of Health Services and Policy at the University of South Carolina Arnold School of Public Health. This project aims to evaluate stakeholders' receptivity and acceptability of community to transition into what we call the learning healthcare communities. In this session, we will briefly walk through what did we do, how did we do it, and what did we find. First, what did we do? Learning health systems are healthcare systems in which knowledge generation processes are embedded in daily practice to produce continual improvement in care. The idea was first conceptualized in 2007 by the Institute of Medicine, which is now the National Academy of Medicine, building on ideas around evidence-based medicine. According to this concept, healthcare organizations ideally should combine internal data and experiences with external evidence to produce knowledge that's put into practice. In LHS, data and knowledge improve patient care, and patients can inform data and knowledge in the cyclic process. When the LHS model demonstrates an innovative approach to the healthcare delivery, there remains considerable barriers to access to high-quality, evidence-based care, particularly in low-resource communities. Further, this cyclic process of improvement is mostly confined within the walls of the health system. It waits for the person to become a patient and has to come to the health system to seek care. This project aims to determine receptivity of advancing LHS to a novel evidence-based healthcare delivery framework called the Learning Healthcare Community. A Learning Healthcare Community, or LHCC, seeks to build on this model by actively involving patients and caregivers in the healthcare process. An LHCC is a community where healthcare organization learns from community members about their health concerns and how to improve their services and provide more culturally sensitive care. At the same time, community members learn from the providers how they can become healthier individuals to achieve a healthier community. LHCC actively listens and builds relationships with patients, community members, and caregivers in the healthcare process, building trust by open discussion with stakeholders about community and individuals in the healthcare process. The learning process, for example, may include doctors learning from their patients what is important for them and understanding their needs. Likewise, patients may be learning from their doctors how to live a healthy lifestyle based on the recent evidence and specific data generated in the community. We wanted to see what would the community think of such a concept. We used Baltimore in Maryland, United States as a setting for this project because it is an ideal location for bidirectional learning between health systems and communities to engage and address social, economic, and environmental forces in an LHCC model. Baltimore is an urban, quasi-segregated city with historical mistrust in the medical care and research. It has an age-adjusted mortality of 40% higher than the rest of the state as well. We conducted a community-based participatory qualitative assessment with a diverse multi-stakeholder advisory board. The advisory board consisted of community leaders, a patient, a physician, a payer, and an LHS expert to collaborate on the planning, conducting, and dissemination of the project. We conducted 21 in-depth interviews and 15 focus groups with 109 participants. 2 independent coders thematically analyzed the transcripts following a grounded theory approach. 38% of the participants were community members and leaders, 29% were healthcare professionals, 26% were patients, and 7% were other stakeholders. What did we find? Based on the participants' responses, we identified 3 main themes. First, health is a priority for many. People want to stay healthy, mainly driven by the motivation of living longer and being around their families. However, not all participants regarded health as a priority in their life. This is particularly true among younger individuals, where other commitments like school and work is their priority. Second, patients seek more than just medical care. While the medical team focuses on conversations that enhance medical care, patients are expecting healthcare providers to touch on subjects beyond medical care, like thoughts and feelings, mental health, social support, and questions that establish comfort and trust between the clinician and the patient. Third, patients want empathy. Patients look for healthcare providers who listen. Home visits was a common theme among both community members and healthcare providers. Some community members refer to the good old days when the doctor used to come to our homes. The stakeholder interviewed in this study believed that LHCC could be a viable model for enhancing the care experience and improving the community health, as long as the following parameters are covered. 1, individualized to each community, include home visits, present research in a simplified manner, incorporate social determinants of health, use collaborative approaches to include patients' ideas, include integrated data systems to track information, raise awareness through community events, align different stakeholders and resources to increase efficiency, and be community-based. When asked who and what should be included in the LHCC, many participants responded that community gathering places such as eateries, markets, barbershops, information centers should be included. Community residents, faith-based organizations, schools are also mentioned as important components of LHCC. The most frequently mentioned challenge was the lack of trust in the healthcare system and research, followed by lack of participation. One participant, for example, said, "They're not going to trust you. They're not going to know who you are. People are very cautious, as they should be these days." Participant suggestions for overcoming these barriers include engaging and involving relevant stakeholders as partners and facilitate open communication. Participants often discuss the need for a buy-in, and one community leader stated, I quote, "Really making people feel like part of the process as you go through it will help with the buy-in." The most frequently mentioned concern was one surrounding data sharing and data security. Other concerns included not following through on the promises and initial plans, and dishonesty and historical mistrust, as well as the lack of compassion and relationship building. Some participants stated that it would be important for LHCC to collect and use personal data, whereas others stated that they would agree to giving general information but not specific personal data. In conclusion, a successful LHS drew from best evidence to tailor optimal care to individual patients and to the learning throughout the delivery of care to improve health outcomes. And an LHCC can bring the LHS concept upstream to the community and build on the LHS model by actively involving patients and caregivers, who are the community in the healthcare process. Other cities can utilize the LHCC model to continuously and actively listen and build relationships with patients, community members, and caregivers in the healthcare process. Lessons learned and challenges discussed by study participants can help health system leaders and communities explore LHCC aspiration to align healthcare delivery within an engaged, empowered, and informed community. In ending, I'd like to acknowledge our stakeholder advisory board members and project teams listed on this slide. Last but not least, the sincerest appreciation goes to the participants and to the Baltimore community at large for providing their valuable time and sharing their essential thoughts. For further information or questions, feel free to reach me via email or social media. Stay well and have a nice day.
That's fantastic. Thank you. Brilliant case study of learning healthcare communities from the US. Thank you, Nabil. So as previously, let me pause briefly and check if there are any quick questions for clarification before moving on with the next panelist, with the next presenter. Let me just pause for the usual 10 seconds or so, the grace period, before we move on. But please do drop your questions for the final Q&A part. And thank you for the questions that have already trickled through. So we will not forget, we will come back to those. Okay. So I see there are no questions there. So that means everything is crystal clear. So well done, Nabil. So let me move on to our next presenter, who is Dr. Bronwyn Gillespie. So she's an anthropologist who worked widely in research and international cooperation in Latin America and South Africa. She has a special interest in access to health for disadvantaged women, girls, and children. And she currently works at the University of Sheffield, Prime NIHR-funded Global Health Research Group. And the title of her presentation is Adolescent Sexual and Reproductive Health Decision-Making in Informal Settlements in South Africa. Bronwyn, over to you, please.
Hello, my name is Bronwyn Gillespie. It's a pleasure to be here. I work at the University of Sheffield in the NIHR-funded Prime Global Health Research Group. My presentation represents research carried out alongside co-authors and partners listed here, and the title is Adolescent Sexual and Reproductive Health Decision-Making in Informal Settlements in South Africa. So here we have background and methods. The research was carried out in response to stakeholder concern regarding adolescent pregnancy rates in South Africa, not higher than in neighboring countries, but enduring despite government investment. The Department of Basic Education and the Ministry of Health have recently signed a collaboration agreement mandating comprehensive sexuality education in schools and direct coordination with health services for adolescent-friendly services. However, implementation is still very uneven. Now, our qualitative study focused on perceptions held by adolescents, especially mothers, served by 4 clinics, their parents, healthcare staff, community figures, and health authorities. We carried out over 80 interviews, 30 of which were with adolescent mothers. So residents of informal settlements share education and health services with the more formal residential area nearby. Many of the girls migrated from rural areas of South Africa to study there, seen as having better access to education. Now, what we found. I called pregnancy an unsurprising surprise. The girls who became pregnant were almost all students at the time. They hadn't wanted the pregnancy. Many described shock finding out about it. However, only half, despite being sexually active, have visited health services or used any contraception. Others described irregular use of condoms or the injection method. We'll talk today about the way that disadvantage and vulnerability increase, first, the risk of adolescent pregnancy, and second, the challenges of coping with motherhood. I've summarized this here as money, men, and mothers. First of all, money, financial situation. There are costs associated with contraception. One girl explained, I didn't have money to get transport into town, so I missed my injection. My boyfriend didn't want to give me the money. At that time, I lived on my own. My mom worked elsewhere. And after birth, several teen mothers dropped out of school. They were very despondent, stating that the money their families had sent from afar for school now had to go to the baby's expenses. This contrasts with the situation of young women living in the residential township area. One was optimistic. She said, my mother works at the municipality. My older brother also works. I'll return to school next year, and I'm also working on starting my own business. Second point, men, gender and relationships. Girls' decision-making power depends in part on the age difference and on the transactional nature of some relationships. One young woman almost finished high school said she had no problem using condoms, describing her boyfriend, he's like me, he's a friend, he's my age. It was generally known, in contrast, that those dating what was locally termed blessers couldn't always insist on contraception. One young man said, she can't decide if she's getting the money. This power imbalance continued after birth. One teen mother, 14 years, came from an impoverished family who relied on her 30-something boyfriend for groceries. He'd abandoned them after the baby's birth. This was especially complicated in informal settlements, and men moved frequently with no fixed address, and even if they were tracked down, didn't have income to contribute. We found several young single mothers in various situations of negotiation with new partners, living in shacks. One, at worst, would call a boyfriend when in need of cash for her children, but did not use condoms. Another was managing to continue her education with a new supportive partner, but was increasingly worried about his demands that he also be a father of a child. Last one, mom, or support from the family. Adolescents themselves spoke of the crucial disciplinary role of mothers, constantly warning them away from dating and to focus on their books. One teacher said, "We're most worried about the ones living here on their own, those who don't live with their parents." Some girls live with extended family, end up with a full load of domestic chores plus schoolwork. Some mentioned that those are at risk of dropping out or even of sexual abuse. Now, regarding coping after the birth, much depends if there's a mother or grandmother to leave the baby with. Many babies are sent to rural homes while teens continue to study in the city. One young woman said she managed to finish exams and is now at university after getting a grant. So the family home was also an important point in terms of negotiating with the father of the baby. Girls living with their own families were in a much better position. They could receive partners' financial support and co-parent, but hold out for marriage with corresponding status rather than having to move in with a man as a financial dependent. Last point, aspirations. Almost all young women expressed anxiety about access to further education and employment. Girls without family support were not optimistic about continuing their studies. One student, not yet a mother, said, "I'm an orphan. I don't see how my uncle will pay for it." Now, moving on to the next slide, informal settlements represent in sharper relief some of the vulnerabilities that can lead to adolescent pregnancy, as well as those that make it difficult to continue education as a young mother, shifting a girl's trajectory towards the reproduction of poverty. We want to invite reflection regarding the circumstances which bring adolescents to the settlements, rather than the settlements themselves. Migration to settlements is often the result of aspirational plans in reaction to unequal access to quality education. These plans, in some circumstances, lead to further vulnerability for teens. Secondly, the fundamental challenge is not necessarily adolescent pregnancy, but adolescent poverty. The way in which motherhood interacts with a girl's education depends on the underlying socioeconomic precarity within which she lives. A point about health equity. Global health literature states, crucial reforms are those that promote gender equality and give women greater control over bodies and lives. However, intervention designs rarely address the underlying vulnerability faced by adolescents. We need to reflect on how categorizing sexual and reproductive health as health means it is most often addressed within health systems, which may distract from the crucial multi-sector focus needed to address structural drivers such as poverty and gender equality. So moving forward, I only want to briefly put up here that our follow-up research in South Africa will focus on facilitating local level implementation of existing policy so that disadvantaged teens enjoy improved support in clinics and schools, those first two bullet points. We'll also be active in using the findings to support advocacy, helping the National Teen Pregnancy Prevention Campaign and the Ministry of Health at national level. Lastly, thanks very much to Dilia Namba and Julie Balin, Prime team at Sheffield University, to Dr. Priya Samapillai in South Africa, the rest of my research team, and Utifet at the MRC for helping me get in touch with community health workers who made this possible. Thanks too to our funders in IHR, and I hope you do get in touch.
Fantastic, fantastic. Thank you very much, Brahman. That's a fascinating case study of sexual and reproductive health from South Africa. So as previously, let me pause briefly and check if there are any immediate questions for clarification before we move on. Okay, well, nothing is coming through. I think we're doing very well. All our presenters seem to be delivering crystal clear material, so there are no questions for clarification at any point so far. So that's brilliant. Well done so far. Okay, so our next presenter, let's move on, is Professor Arima Mishra. She is professor at Azim Premji University in India, and her work is mainly in the area of medical anthropology. She unfortunately cannot be here with us at the moment, but she has pre-recorded her presentation, which we'll play in a moment. But then Dr. Rajesh Joseph will stand for questions afterwards. And Rajesh is Associate Professor in the Azim Premji University in Bangalore in India. He teaches courses on informal labor and livelihoods. His current research interests cover the domestic workers, migration and health of women garment workers in Bangalore. And prior to joining as faculty at the university, has worked for more than 15 years in the development sector. Okay, so without any further ado, can I turn to Arima's presentation, and then with a caveat that Rajesh will come back later for questions. Arima, over to you, please.
Hello everyone, my name is Arima Mishra. I am a faculty member in Azim Premji University, Bangalore, India. I'm going to share the findings of a recently concluded research study that explored the health vulnerability of women workers, particularly working in garment factories in one of the states in South India. Let me begin with giving you a context to this research study, because there was a specific trigger to why we conducted this particular study. So one of the provisions as part of the welfare for workers, particularly working in the organized sector, is that it allows the families of the workers to apply for financial assistance, particularly to meet with funeral expenses in the wake of a worker's death. A cursory scrutiny of these applications reveals somewhat of a disturbing trend. And that trend, particularly we looked at the data between 2017 to 2019, which shows that there is an increasing number of deaths of women at a relatively younger age. And most of these women worked in garment factories. And that really prompted us to figure out the reasons for these deaths, and in the process explored what determines the health vulnerability of women workers, particularly working in these garment factories. So we did a collaborative research. This is with colleagues in the university, along with the commissioner, assistant commissioner of labor of the state government. We did adopt a qualitative inquiry, and we used a couple of tools. To begin with, we used social autopsies. So we adapted this particular tool, which is widely used in the maternal deaths literature. We also undertook in-depth interviews with the workers along with focus group discussions. And also we visited 3 factories to be able to understand what the working conditions of these workers are. Interestingly, the social autopsies, and which were carried out with the family members of the women who had lost their lives, actually revealed nothing. It revealed silence, and that is that most of the deaths were projected as sudden events, abrupt events, and nothing in terms of the vulnerability, the prior risks were actually captured in these narratives. In fact, what the husbands and in some cases the relatives spoke about is actually they highlighted the agency of the women, how everything that the women had perfect control over their lives, or in some cases they actually normalized even if they were experiencing some of the health conditions. As you can see, in one of the cases, the husband just says that she never used to complain about her work or pain, but often she used to visit the hospital with complaints of tiredness, and which was considered as normal. However, the narratives of the women workers who are currently working in the factories spoke volumes about how the work conditions, in fact, impact the health. Predominantly, the health was spoken in terms of relating to how body is treated as a machine. The entire life revolved around how many pieces to stitch, what are the targets to kind of chase every hour, and how overtime was something that everybody had to undertake, to the point of actually compromising on food, water, and also in some cases using restrooms. Torture was used as a colloquial expression of the constant pressure that women actually felt both in their body and the mind, and verbal reprimand, particularly by the male supervisors, which were often sexual in nature, was also used in terms of trying to talk about how it really impacts their mental health. Heat, bodily heat, was again another kind of generalized expression which they spoke about, linking to many health problems, particularly relating to gynecological problems. The problems relating to menstruation was something that which was widely talked about by the women workers, and which affected women differently depending on which life stage they are in. So in one of the cases, a very young 21-year-old women garment worker actually says that her mother asks her to stop working in garment factory because it would have an impact on her marriage, because she really suffers from irregular menstruation. The existing care that is there for accessing care, the institutions largely are geared towards more towards childbirths, and hence have not really adequately addressed the lot of these problems that women have spoken about, and which is a concern because this has not really taken into account the changing needs of labor force, because traditionally many of these actually in recent times more and more women have joined the workforce, particularly the garment industry. So what do these garment worker stories actually tell us? In most of the cases, many of these health problems which have been shared either go undiagnosed or untreated, naturalizing the suffering as women's problems. The existing focus, a lot of kind of attention that has gone to labor, labor issues, has always been on work in terms of availability, retention, minimum wages, which are very, very important. But the conditions that are needed to create a healthy workforce are not really seriously addressed. In the process, health and issues around labor have always been worked in their own silos, both in terms of policies as well as research. So the study, particularly highlighting these women's experiences, strongly suggest that while health issues in that sense need prominent research and policy attention, if we are really interested in seriously looking at the social determinants of health and promoting intersectoral actions. Thank you.
Brilliant. Thank you very much, Arima. Really insightful lessons and fascinating results. Excellent. So can I pause at this point, as previously, for any quick questions for clarification? I think we are very much on a successful road of everything has been very clear and no questions so far. But I don't want to shortchange anybody who may not have got everything. And can I also encourage the participants, please do drop your questions in the Q&A section on the platform, and then feel free to just put your messages, maybe introduce yourselves in the discussion forum. Okay. All right. So I see there are no further questions at this point. So let me move on with our last presenter, who is Dr. Duke Duong. So Mr. Duke Duong, Mr. Duke Duong Minh Duc, apologies for that, PhD, is a public health researcher and lecturer with recognized publications in reproductive health, knowledge translation, and implementation science. For over 15 years, he has engaged in writing and publishing many peer-reviewed articles and a number of public health topics, including urbanization. And his presentation is entitled Using Digital Data and Dashboards for Urban Health Decision-Making in Vietnam. Duke, over to you, please.
Hello, ladies and gentlemen. Thanks very much for joining me today. And my name is Duke, coming from Hanoi University of Public Health. And my presentation today is about using digital data and dashboard for urban health decision-making in Vietnam. So as you all know, Vietnam is a developing country, and a very large number of the population are migrant workers who travel from this city to other city to find a better job and also better income for their life. But unfortunately, these migrant workers, they often underreport and couldn't access for the current system of health and current system of also social security, which makes them a higher risk of getting better health and better life. So based on that, in 2017-2018, we raised a research question that how do the local government in the urban cities could plan to respond to the needs and demand of the urban migrant for the regarding the health priority and also regarding the social issues, and to what extent the urban migrant could be involved in the urban planning processes. So we choose Hanoi to perform this study because Hanoi is one of the biggest cities in Vietnam and with the highest number of the urban migrants in the country. So before coming to the method, you can see here it is a short slide about the health system in the country, and you can see that we have from the government, we have the highest level, the Vietnam Ministry of Health, and under that we have Provincial Health Bureau, and under that we have the District Health Center, and these two Provincial Health Bureau and District Health Center are in charge of trying to do the urban planning for all of the people in the surrounding or catchment areas. So for the method to trying to answer the objective and the research question, we do the in-depth interview with the local government, such as health policy making, such as urban planning decision maker, and so on. And we also do 5 focus group discussion with the people, with the migrant worker who are living in slum area. And as I said, we done that in 2017-2018. So this is some of the picture about the 4 different types of slum that the migrant worker who traveling from other province to Hanoi who are living. The first one is different houses. The second one is a shelter camp for some of the construction workers. So they build the camp if they are construction worker and under the construction site. And this is some of the old collective living quarter that also be one choice for some of the migrant workers. And another choice is they can living in some abandoned areas like these houses. So all of these places are very in poor condition, and actually they are slum areas. So after collecting the data, we use and develop this theoretical framework to trying to understand the data we have. So this theoretical framework is developed based on 4 main issues. The first one is the key actors, such as the health planner, service provider, community representative. And we're trying to analyze their role in generating, disseminating, and also using data through the planning processes. The second one is approaches and processes of developing and implementing the urban plans. And the third one is the characteristic of the available data, such as the timeliness, the accuracy, the quality, and availability of the data. And the fourth one is a conceptual facilitator and constraint to the data informed planning processes. So we got the following result to present based on how we interview. First one, the health is a priority within Hanoi, and often health planning process using a combination of top-down and bottom-up processes. So you can see here, this is how a plan in Hanoi have been developed. The first one we based on the government general plan, like the 10-year general plan of the government and or the national strategy of the country. And then after that, the Ministry of Health trying to do some long-term and mid-term strategy for the whole health system. And under that, the provincial and district health center, they develop their own strategy, and also there's the annual plan trying to adapt to the general plan from the government and also from the Ministry of Health. And the planning process often starts from August when they collect the data, and in October and November they're trying to do some financial plan, and then in December and January they submit to approve for the whole planning, and often in March the plan will be accepted, and they can start it to implement the plan since June or July, which is quite late. This is a health data information system in the country, and at the highest level we have the Vietnam statistical system, and we do the bottom-down system to trying to collect the data and reporting from the lowest level commute. Through that, we have the data to district level, and then provincial, and then come to the national level. So this process is getting the following weaknesses. The first one is that we only use mostly paper-based, and it's very limiting our ability to update the data to follow very, very timely evidence-based decision and policies. And the quality of the data is quite low because it's mostly focused on paper-based and it's not timely. So it takes a long time for planning and very short time to implement and very, very few time for evaluate the implementation. And also the development of the health plan depends a lot on the development of social and economic plan. Like this year, we got the COVID-19 and most of the health plan could not be done at the plan. So about the quality, data quality, as I said, it's very, very unupdated, very, very low quality and very difficult to rely on that for the health decision-making processes. And mostly all of the data now is not capture the migrant worker who are the focus of our study, saying that the migrant worker is often a kind of migrant, marginalized population for the health care and also social care in Vietnam. So that's one of the reasons of the study, and hopefully in the future we can use the result to develop and involve more migrant workers in the health planning process. Thanks very much for hearing and hope to hear from comment and question from you.
Excellent. Thank you very much, Duke. That is brilliant. As previously, let me pause briefly for any questions for clarification. And in the meantime, can I encourage all presenters to unmute your webcams? Maybe if you keep your microphones muted for the time being. So get ready for the question and answer session. And we will move on in a minute. Let me just briefly pause and see if there are any questions for clarification. Okay, so there are some questions for substantive Q&A session, but no questions for clarification. So I take it as Duke's presentation has been as crystal clear as everybody else's. So well done, everyone. So good. Okay, so this is the point where we reflect on the presentations and answer any emerging questions. Okay, the very first question actually was from Patrick Wilson, who did not direct this to anybody in particular, but he posed a really interesting kind of conceptual issue. Interested to know how we're defining urban. Is there a minimum settlement size, density, or is it to do with municipal, rural districts? And are there differences across WHO or health systems global regions? This is something that I would actually like all presenters to perhaps reflect from the context of your own studies, if that's okay with you. So maybe kind of conceptual question to all of you. So if I will go in the same order that colleagues have presented, obviously Minus is not here with us. And if I could ask each of you maybe to spend a minute or two just reflecting on how would you define urban as a context from your own study. Nabil, if I could start with you, please. Please unmute your microphone and go ahead.
Thank you, Todd. That's a great question, Patrick, and I think it differs from setting to setting, as you may assume. Specifically in the US, there has been a lot of discussion about particularly defining rural, which is the flip side of urban. And that has been there being formulated several tools actually and metric system of defining rural and urban areas. And I think I will just point out to two most common ones and also generate back to the study that we did. We refer to the US Census Bureau, where they define urban as any city with larger than 50,000 individuals. So most of those, at least the ones in the US, has been specifically focused on population size. So any size more than $50,000 have been 50,000 individuals, has been considered as an urban area. And there are RUCA codes, for example, rural urban area codes, that identify certain cities and zip codes based on their population sizes and metropolitan versus non-metropolitan areas.
Fantastic. Thank you, Nabil. That's good. Bronwen, can I turn to you? How would you define urban from the context of your study, but also maybe broader experiences that you bring in? Please go ahead.
Hi, thanks for the question. So actually, for the purposes of our study, we were already specifically targeting urban areas because we were interested in the way that informal slums were becoming built up on the edge of capital cities. And those were people who were defining that as urban as opposed to the rural where they were coming from. So these were areas that were actually in some cases wasteland that had become recently and chaotically urbanized because of the density of the small huts that were growing up on the very edges of already residential formal urban neighborhoods. And so they were growing up there to gain access to services which they deemed to be urban in terms of better quality education, better quality health services. And I'm sorry I can't answer in terms of what that means about density of urban versus rural. That'd be something interesting to look up, especially the questions that were raised about how that's defined nationally versus how that's defined by WHO and what kind of impact that has on policy. And so I'll leave that there so that someone else can answer in their context.
Brilliant. Thank you, Bronwen. That's excellent. Okay, so Rajesh, can I turn to you and request you to maybe reflect on that conceptualization of urban from your own context? Please go ahead.
Yeah, so the census of India here, as what Nabil said, considers urban as more than 50,000 size, but it also has a caveat that percentage of population who, like 75% of the population, if they are in agriculture, then it's considered as a rural population. If more people are not in agriculture, but more on non-agriculture work, then that is considered as urban. So in India, we have a very peculiar way the census does it, though the census might consider that as a census town, which means it is come out from a rural to an urban, and they consider a census town. But politically, mostly, it might not be considered as urban because a lot of schemes and all that, they might let go of that. So there's always this problem of what is urban and rural. But in our case, we also know that most of the factories have moved into the rural space because of the minimum wages, which is less. So for us, when we did this government workers, we also went into the rural space because most of the workers do come from rural to urban, traveling 60 kilometers every day, where the buses are arranged for the workers to travel up and down.
That is excellent. Thank you. Brilliant. So great kind of diversity, but also complementarity in some ways in approaching the conceptualization of urban context from the population size, from the kind of geographical location and so on. Duke, can I turn to you briefly, just to, with the same request, to reflect on what does urban mean in Vietnam or in Hanoi context? Over to you.
Yeah, thank you, Tolly. Yeah, I think we don't have an exact definition of urban in the study, but we have a kind of opposite definition in our study. We call slum area, and we use that definition of slum area in urban, meaning that using the UN Habitat definition, like if they do have enough space, or if they have durable housing, or if they have easy access, and so on. You can Google and find the 5 different criteria from UN Habitat to define a slum area. And a slum area is the main definition in our study. We don't have a very exact definition for the urban in our study. Yep.
Okay, fantastic. Brilliant. And I was also going to kind of signpost colleagues to the UN Habitat, but overall great complementarity. So there is no agreed universal definition of urban. So it's a conglomerate of very much kind of geographical population size, as well as the nature of the context. So that's brilliant. Okay, our next question is actually from one of the presenters. So brilliant to see this engagement for a change. So Branwen is actually asked a question for Dr. Nabil. Dr. Branwen has asked a question to Dr. Nabil. So preserving the titles here. So the question is the kind of issue of learning healthcare communities, is this more important for certain types of communities, for example, disadvantaged? And I'm very curious about people's interest in home visits, especially if some participants suggested lack of trust. How do you understand this interest in home visits? So Nabil, can I turn to you briefly, if you would like to take a minute or two to reflect on Branwen's question. Please go ahead.
Sure, thank you. And thank you, Branwen, for this great question, actually. So yes, you're right in a sense that a learning healthcare community could be more targeted towards certain communities. I would argue that there are two prongs to that. So it might be a little bit easier and kind of to implement, specifically among more affluent communities where there are more resources. So if we're talking just about feasibility of implementation and getting to see the results, it might be easier for those. But if you're looking more at the impact and how can we make and see a change, specifically in terms of a lot of health outcomes and decreasing health disparities, then it's the opposite. It's just targeting it towards communities where there's a lot of disadvantaged populations or populations who have been historically underrepresented and underserved in the healthcare research system and as well as the healthcare delivery system. And then to answer your second question related to home visits, actually we were very surprised when we heard about those home visits themes that were emerging, and it emerged in multiple focus groups that we had. And I'll just give you one quote actually from one community resident that we thought would explicitly identify what they were targeting. So that one patient or community member said, "I think it helps for the physician to come out of the building and into the community, because then you can also see the environment in person. That really helps." So I think that their point and their issue was they are feeling alienated, specifically in those communities that were underserved, and we were referring to they had to cross multiple barriers, not only like the physical barriers of transportation, but other barriers, for example, costs and others, to go to that large hospital in the middle of the city in Baltimore. For example, they gave us one example also related to having a very small hospital in their community in West Baltimore that used to provide them care at convenience, and they said they removed it from our community, which is basically it shut down, whether for financial issues or others. So they went back to the history of having the providers come to the house back in the old days, where they established that face-to-face encounter and one-on-one engagement, if you will, and that provider would know you, your family members, etc. So that's where they were coming from related to home visits. I hope that answers your question.
Brilliant. Thank you. And there is, of course, always an opportunity to follow up. So if colleagues, you feel you have a follow-up kind of question or follow-up inquiry, please feel free to reach out to the presenters. I'm sure they would be very happy to maintain that exchange afterwards. Okay, brilliant. I think the next question was addressed to Minus. That is again from Patrick Wilson. So the question was, women's size would seem to be very strongly embedded cultural issue. How easy is it to change the attitudes to body shapes? But perhaps if I could turn the question slightly around, and maybe if I would request Branwen and then maybe Rajesh to reflect on what is the role of culture in the context of your studies, and also how easy or how difficult it is to kind of change the attitudes and behavior and practices. Did you have any kind of reflections or perhaps results that help illuminate this issue? So Branwen, you're unmuted. I think you're ready to go. Please go ahead.
Oh, sure, thanks. Yes, actually, across so many sectors in public health, it's interesting to look at the role of culture. So we actually went in to the research aware that there had been some work published by South African authors on community resistance, community moral norms surrounding sexual and reproductive health, and that a lot of adolescents feel really concerned, worried, lack of privacy, judgment issues in going to visit clinics. So what we found in the end, however, is that it's interesting to look at the extent to which training and investment in healthcare professionals can really help bolster their professional roles and move beyond their cultural reservations. And we felt like quite recently, the efforts of the state had caused a shift in the way that they felt that it was best to be protecting youth. So their stance as a professional health worker was very much about needing to get contraception to adolescents who need it, rather than as a mother or a parent or a community member, they would have previously preferred to really insist on abstinence talk. So South Africa is really in the midst of this transition where they're recognizing that youth culture in its present day is changing, and adults, especially service providers, kind of need to get on board to be there, because so many youngsters are actually having unplanned pregnancies, and those are students, those are girls who would like to have a career trajectory, and it's just this communication between the generations, which is quite challenging in a cultural sense. So just to end that off, what we felt that was actually a more crucial issue was investment in human resources in the health system, and making sure that local level service providers were listened to in their suggestions of how the health system can be more responsive, and following up on that, because South Africa does have quite progressive sexual and reproductive health policy. However, the implementation at ground level was lacking for some of the cultural reasons, and a lot of times just implementation, operational limitations, that I think by focusing on local level suggestions and making sure those resources are getting there and that management is backing up local service providers, I think a lot of progress can be made. I'll leave you, let someone else give their 2 cents for that.
Oh, brilliant. Thank you very much, Branwen. That's really interesting insights. Okay, so having heard kind of some reflections on the culture from the sexual and reproductive health kind of perspective in South Africa. So Rajesh, do you want to reflect on it from kind of
Yes,
government South India perspective? Please go ahead.
yeah, so one of the things that we did have a difficulty, it's because of the cultural perception. As Arima had said, when we started doing the research, we started actually speaking to the husbands. The one of the problems that faced was the husband didn't want to accept that the wife was going for a job, right, to support the family, because he wanted to say, I support the family because she just wanted to go to the job. You know, so there's a reluctance to accept that the wife was also contributing to the household making. So that it is also because of the cultural perception we have in India. The other thing is about the sexual reproduction itself is not talked about openly. So the whole thing is you can't talk on the shop floor where 80% of the women 80% of the workforce is women, and the managerial level or the supervisor level is men. So you can't openly talk about saying that I have a sexual reproductive problem, right? So that was a huge disconnect which happens on the shop floor, because you can't connect it at all what is happening. So one of the things is, even for us it was difficult till one union leader said, why are you are so ashamed to talk about it? If this is it, so let us say what it is about. So it took a man because his wife was there in the group, to actually open up that topic for us, to say that, yes, the heat which actually contribute to the menstrual cycle and all that came out, but still the perception that something of this can't be talked in open, because it has to be culturally, you can't talk it out when men are there. So this is what happens on a shop floor, because the men are the supervisors. They just can't understand what women are going through at that point of time. So they have these kind of lewd remarks which is coming in, at that point of time. Why can't you work fast? Why can't you do this? Why can't you do that? So just giving you that cultural aspect. So somewhere down the line, this has to come in open, and I hope our research brings that up to the forefront.
Oh, brilliant. That's really interesting. And of course, culture is a very kind of multifaceted and multidimensional concept that includes gender, that includes kind of the societal norms and taboos and expectations, and as you say, Rajesh, also kind of that also carried into the employment and workspace expectations and job descriptions and these kind of things. So that's really kind of important. Brilliant. Okay, I think you, Rajesh, have asked a question about what is the community's response to data protection. Maybe if I could direct this to Duke, if that's okay, even though your study was largely about decision makers, but I think the kind of data and decision making is very much kind of an inclusive concept. And I think, as I remember correctly, you were also sort of focusing a little bit on the migrant workers too. So would you be happy to come in, Duke, reflect on...
So one thing, sorry, Tobin, it was also
oh, please go ahead.
To Nabil, because he spoke about data from the community point of view. So I was more interested to say that, data protection now is becoming a little more when you work with community, to say, do we share community's health profile? I mean, so I just wanted to ask Nabil, because he did mention in his talk.
Okay. Well, maybe if I could ask Duke to come in briefly, if you have any comments, any reflections on this, and then I will turn back to you, Nabil. Is that okay? This is the equitable distribution of questions. Please go ahead, Duke.
Yep. Thank you, Tolif. I think I'm not very sure it's very engaged in much of the problem of our research, but when coming to the community response to the data protection, they want three things, I think, that in Vietnam. The first one is that they want, when we do the study, they want to see the report and the feedback after we got the data analysis. So that is very important now. And if we don't do that, they will call and ask for what we are doing with the data they had provided before. The second point is that they also want their name is not there, and none of the people can identify they are joining the research. So that is the second point they are involved, but they want to hear. And the third point about the community is that they want their kind of data is kind of prohibited to any other purpose rather than research. So it was changing a lot from some years ago. When we do the studies, they are not very strictly on following what we will do with the data, but now the people in Vietnam is very concerned about that. I think maybe it's one of the problem coming from the COVID-19 when the people is very afraid of recognizing their maybe suspicious status and something similar when they reveal their data information.
Excellent. Thank you. Brilliant. I'm conscious of time. We've got about 5 minutes left in the session. So I will turn to you, Nabil, but maybe if you could, in your kind of intervention, if you could cover Rajesh's question, but maybe also add any final remarks that you may want to add for the closing. And then I will do the same with Branwen, Rajesh, and Duke too. And hopefully we'll have a minute or two right at the end for any closing remarks from me as well. Is that okay? I can see you nodding. Thank you, and please go ahead.
Thank you. And just to kind of quickly answer Rajesh's question, and that's a very important question as well. And we did explicitly ask our residents, like, are you willing to share your personal data? And because Baltimore of the historical mistrust that we've talked about, we knew that data sharing would be very kind of problematic. We were pleasantly surprised to see that there was a general willingness to share basic personal information, but they kind of stratified it into different concepts. So they explicitly clarified that there's a difference between sharing health-related data, for example, walking steps or blood pressure, etc., versus other more intimate personal data. For example, they told us financial data. Obviously, they wouldn't go into there, right? But we wanted that kind of differentiation because this was a holistic concept, not only focused on clinical aspects and health, but more to incorporate the social determinants. And there was also clarification that certain personal information among specific groups might be a little bit trickier. For example, persons in the LGBTQ communities or people with HIV or other sexually transmitted diseases, there's that still stigma about them. So those communities were a little bit more hesitant when we asked them if they are willing to share their data. So that's related to the data. And I think that, like, just in closing, I think we thought this would be a great opportunity to kind of explore it and see how we can bridge this gap between health system, the traditional gap between health systems, research and evidence, and the communities, and bridge them all three together. And thank you for this great session today.
Absolutely. Well done. Thank you, Nabil. That's brilliant. Okay, Branwen, can I turn to you for any maybe final words of wisdom from your side, any final issues that you would like to raise? Please go ahead.
Wisdom might be kind of a long call, but just wanted to say that it was very interesting to listen to all the presentations, and I feel like together, between them all came through a message which, anyway, from my point of view, is very interesting, and that's about how we can draw attention to the fact that a lot of health questions really go beyond the health sector. And I think that we all know that. I mean, we're very versed with social determinants of health and other approaches, but in practical sense, it seems a lot of times health issues are still measured on the body and still responded to through a health services type approach. And so it's nice to have these spaces where we start looking at how to avoid addressing it in that narrow way, and to encourage more multi-sector practical action as well as just theoretical reflection. So thanks for your contributions, and good luck with the rest of it.
Excellent. Thank you very much. Brilliant. Rajesh, can I turn to you for any brief last comments? Please go ahead.
For this wonderful session on urban health, because I think in our country, urban health is not a lot more talked about subject, because it is rural health which is being talked about a lot here, rather than the urban health. And as what we heard, because it's a lot of migrants, India is also going through this phase of a lot of migrants coming into the urban, which is not spoken at all. And I think that's where some of the research has to go in, and also to see how do we actually try to address this whole migration and women actually coming into the workforce and what it means for women's health altogether. Not only trying to look at from a maternal health, but also from the well-being of women health.
Excellent, thank you. Brilliant. Duke, can I turn to you for any brief last words? Please go ahead.
Okay, thank you, Tulip. I think that I'm very happy to join in the team, and good luck and thanks for sharing, Tulip.
That's fantastic. Thank you. Okay, well, I think we're just about out of time. No time for any closing remarks, but well done, everybody. Congratulations, thanks, and good luck. And please stay in touch with each other. Thank you and goodbye.